So I'd like to thank Fauzia for presenting for today. And please continue. Sorry to interrupt.
Thanks, Ellie. So, and then we'll talk a little bit about pain, motor control, and then we'll go through some anatomy of the different parts of the core and how we can integrate that into practice for gaining some true value when we're treating our patients. So first we'll just talk briefly about types of motor units. There are basically two types of motor units. We have the slow twitch and the fast twitch motor units. So the slow motor units, they're going to be, contraction speed is slow, their force is very low. They're recruited at a very low percentage of maximum voluntary contraction, so less than 25%. It doesn't take much, so their threshold is very low. They're easily activated. They can stay on for a long period of time. They're fatigue resistant. And their role is to control normal functional postures and unloaded movements. So when you're standing for long periods of time, these are your postural muscles that are working. When you're lying down and need to do things at a very low level or a low load, you're going to be using your slow motor units. In contrast, you have your fast motor units, which are high threshold. So they're going to contract fast. They're going to have a high contraction force and produce movement. So you're going to, recruited at greater than 40% of maximum voluntary contraction. So if you're planning to perform a fast movement, like you want to quickly bend down, or you want to squat, or you want to reach up for something, you're going to recruit your fast motor units. So they're quite insensitive, meaning their threshold is high. You need to have a higher stimulus in order to recruit them. And these muscles are going to get fatigued very quickly. So in less than 2 minutes, these muscles are going to fatigue. And their role is to accelerate movement or for high load. So, sprinters are going to use a lot more of these fast motor units than somebody who's doing long distance type of movements. So many times these will be called, you might see type 1 and type 2 motor units. And again, type 1 are the slow motor units and type 2 are the fast motor units. Anybody have any questions about these? You've seen this before?
I think it's okay.
Okay. So again, just to review, the low threshold is slow motor units we're going to use for postural movements, maintaining your posture, normal functional movements where the limb is unloaded, or you're doing trunk movements, unloaded trunk movements. It's going to be a slow recruitment, static, sustained, and these muscles are non-fatiguing. High threshold, or the fast motor units, their function is for accelerating movement, rapid movements, large or sudden shift in the center of gravity, so movement from standing to lying down, or running, high force, heavy loads, and they're going to consciously contract these muscles to their maximum capacity. So we're going to be recruiting these muscles fast and at a high load. So for low threshold, when you're training these muscles, if the exercise or the task is going to be performed for greater than 4 minutes without fatigue or needing recovery time, then at least the first 1 to 2 minutes of the exercise or task will be using low threshold dominance. Therefore, if you want to train these muscles, you're going to be trying to do it for a longer period of time. So you're trying to make these muscles work for a longer endurance. The high threshold muscles, if you cannot perform the exercise or task for 2 minutes due to fatigue, then that exercise or task will be using high threshold dominance. So even with a low load, if you're doing it for less than 2 minutes, then you're going to be using that fast motor units. Okay, so let's talk about pain and motor control. So initially, the studies that they were performing showed that as soon as you had pain, the muscle would turn off. That the muscle in the area would turn off. But the more research that they've been doing, it's indicating that you can also get an increase in muscle activation with pain. So you can get muscle spasm or increased tone in the muscle. So the latest research is showing that pain can alter motor control, and it's very unpredictable. Depending on the task, pain can increase or decrease in muscle activation. So we have to be aware of that and not just assume that the muscle is inhibited. So I want you guys to just stand up for a minute. And once everyone is standing, I want you to try something. So you're going to stand up and put your hand in your back. So just outside your spine, you're going to stand up. You're going to have, let's say, your left hand just in the muscles on the left of your spine. Okay, relax your muscles, and then I want you to try and just raise your arm forward. Up, just do shoulder flexion to 90 degrees and then back down. Okay, so what you should feel when you do that is you should feel some muscle activation happening where your finger is in your back. Has everyone been able to try that?
Shoulder flexion.
Shoulder flexion, so right arm shoulder flexion.
Right arm shoulder flexion. Yeah, that's it.
Okay, so you're gonna, when you do shoulder flexion with your right arm, either on your right, in your right lower back or your left lower back, you're gonna feel some muscle activation happening, right? So these are the muscles, the core muscles that are working. Even though you're using your limb, your upper arm, you're still getting the activation in your lower back, and those are those postural or slow motor units of your core that is working. So that's just an example to show you that it doesn't matter what you're doing, your core muscles, your spinal muscles are going to engage regardless of the movement. Okay, so the rest of the exercise, the rest of the presentation that I'm going to do, we're going to talk about these core muscles. Okay, so first I'll talk about global musculature. So these are your moving muscles. So in your abdominal area, there are some global muscles, and then there are some stabilizing muscles. The global muscles are the outside muscles. So the rectus abdominis, internal, external obliques, spinalis, iliocostalis, glute max. These are the muscles that create movement in our spine. These muscles are typically larger torque-producing muscles. They contract to elicit or control movement. So when we want to move our spine back and forth, if you want to bend down, you're gonna have a recruitment of your global muscle system. So activation is direction dependent. If you want to move forward, you're going to produce the contraction in muscles that allow you to move forward. They can also co-contract or give rigidity if needed, if there's a great enough load. So let's say you wanted to pick up a crate that had more than 50 pounds in it. Now you're gonna also recruit the global muscles for this. But if it's a very low load, then likely you won't be contracting these muscles. You're going to be contracting your segmental muscles, which we'll talk about next. So the other reason for using these global muscles is to protect a pathology. So if you have a spinal compression or a spinal, let's say a spondylosis, you're going to use every muscle in the area to create a compression. So that's another way that you'll be using these muscles. Or sometimes if your core muscles or your stabilizing muscles are injured or they're inhibited, then we'll also turn to the global muscle system for contraction. So these muscles react to pain and inflammation and can lead to a painful spasm. So oftentimes when people talk about aching in their backs, or you feel their back and it's very solid and hard, those are typically times when the global muscle system has kicked in and they're hypertonic and they're in a painful spasm. So a lot of times, you know, we try to treat this with massage or some modalities to try and calm down the hypertonicity. But what I'm going to talk about in a little while is that's not necessarily the best way to treat this. We need to figure out what's causing the hypertonicity in these muscles, and when we can figure that out, if there's an inhibited core, then that's truly what's going to help you to get the global muscle system spasm under control. Okay, so we'll talk about that in a little bit. Anybody have any questions so far about this, the global muscles? Okay, so we're good? Okay, so typically when we do treatments in physiotherapy, we're often trying to strengthen these muscles. We often tell the patients to do exercises to strengthen their back. Or we treat the muscle imbalance by stretching these tight muscles. So, but evidence is now suggesting that this approach may not be optimal. Emphasis should be on training the inside or the stabilizing muscles. This is called, you know, we're trying to train the core. So what is the core? The core are the local or stabilizing muscles. So part of this group is the transverse abdominis, the posterior fibers of psoas, pelvic floor, the medial fibers of quadratus lumborum, and multifidus. So let's just look at a diagram here. So as you can see, the transverse abdominis is quite on the inside, and we'll see another diagram of this, but they're the innermost layer of the front abdominal wall. Then you have your multifidus in the back, and you've got your pelvic floor underneath. So together, this whole system makes up a corset, or so when all these muscles contract, the abdominals are going in, the multifidus is going in, and the pelvic floor is going up. And what that does is it creates a compression like a corset for the spine. So these stabilizing muscles, they don't produce movement. They typically work at a lower contraction level, and they're mostly type 1 fibers. They function independent of the direction of movement. So like we did, you know, using your arm, moving your arm into shoulder flexion, you're going to get contraction of the stabilizing muscles in your spine regardless of what direction you're moving. So if you do that exercise again, you'll see that if you move your arm up into shoulder flexion to 90 degrees, you're going to have contraction in your lumbar spine of the your core muscles, and then when you go back down into extension, you're also going to get contraction of those muscles. So irregardless of the direction of the movement, these muscles are going to stiffen the spine and control what we call the neutral zone. Okay, so let's first talk about the pelvic floor. I'll just go, we'll just look at a diagram really quickly of the pelvic floor muscles.
Excuse me, Fozia?
Yes?
Okay, exactly what is the neutral zone?
Okay, we're going to talk about that in a minute, okay? Just hold on. Hold on 1 second, and then we'll talk about the neutral zone, okay? So we'll just go through pelvic floor muscles, the layer of muscles that stretch from the pubic bone at the front to the coccyx at the back. It is structured like a muscular trampoline. Frequently overlooked, even though they are one of the most important muscle groups in the body. So being a part of the core, they're also contracting all the time. They contribute significantly to sexual response, guiding the baby's head down the birth canal during childbirth, and providing support to the bladder, uterus, and bowel. So these muscles are like a trampoline at the bottom, and they're protecting all these organs that are inside. And when they contract, they're actually helping the bladder and the uterus and the bowel stay in their position where they need to be. Oftentimes, if you have a prolapse, then you're going to have problems with your pelvic floor as well. A strong and well-working pelvic floor helps you to hold on to a full bladder and to wind when you want to. your pelvic floor muscles tighten to prevent leakage of urine when you cough, sneeze, laugh, and move. So if someone's been diagnosed with urinary incontinence, we're going to work on pelvic floor training in order to help them with the pressure that builds up when they cough or sneeze that has the leakage that occurs. So, we've got the pelvic floor muscles from the front all the way to the back, and if we do a cross-section, we'll see, there's different layers of the pelvic floor and different muscles that contract in the front versus the back. So sometimes we get people to feel different parts of the pelvic floor just based on how they're sitting. If they're sitting more on the front of their pubic bone and contract, they're going to try to contract your pelvic floor. If you pull up, you're going to feel more of the front muscles pulling up. If you do a little bit of a posterior pelvic tilt and sit back on your sit bones and contract, then you're going to feel the more posterior part of your pelvic floor muscles. And when we do pelvic floor muscle training, we're trying to make them, some people cannot feel the difference between the front and the back, and sometimes we just need to have them start in neutral and just work on just trying to contract and do a Kegel exercise. So the pelvic floor muscles are frequently weakened by pregnancy and childbirth, and they require special attention during this time. Pelvic floor muscle weakness can result from lack of use, the weight of the baby on the muscles in pregnancy, hormonal changes of pregnancy, stretching of the muscles during childbirth, regularly straining to use the bowels, pushing or straining to finish emptying the bladder, lots of heavy lifting, and carrying extra weight. These muscles can also continue to weaken as a woman ages and experiences the hormonal changes of menopause. This means that minor problems that start after childbirth may progressively worsen with age. So anybody have any questions about pelvic floor dysfunction and what happens? You've all seen, cases of this?
Yeah, I think we've all seen cases of weakness of the pelvic floor.
Okay.
The only thing.
So how do we retrain the pelvic floor?
Okay.
So the first thing is, yes?
Yeah, what I was going to say is that for a long time we didn't appreciate the importance of the pelvic floor in as much as stabilization of the spine is concerned. And I think this is a new concept that we're starting to understand now. But in terms of urinary incontinence, stress incontinence, and things like that, then that we were aware of.
Okay, great. That's a very good point. So, this is very important to note that when we're doing stabilization, we're also, the pelvic floor, the TA, Transversus, Abdominis, and the Multifidus are all wired together. So when you contract, let's say you're teaching somebody to do a transverse abdominis contraction, they're going to automatically pull in their pelvic floor if it's engaged or if it's the nerve conduction is intact. So sometimes we need to focus on pelvic floor on its own in order to complete that corset effect, but sometimes it just comes in anyways. And if you practice this on yourself, you'll see that different muscle contractions will pull in the pelvic floor. So daily pelvic floor exercises. So when a patient has pelvic floor dysfunction, then we are concentrating on pelvic floor exercises to reduce the risk of urinary incontinence. It makes it easier to contract and tighten the muscles after childbirth, lessen the risk of stress incontinence, which is the leakage of urine during cough, sneezing, laughing movements. Kegel exercises, starting pelvic floor exercises within the first few days after childbirth will help the muscles to recover more quickly. Even women who have had stitches or a C-section can do pelvic floor exercises immediately. They don't have to wait for healing to occur. So actually, pelvic floor exercises help the healing to occur faster. So the way that, there's different ways to get your patients to understand and work on pelvic floor.
Fozia, Abraham has a question.
Yes?
Just a minute.
I'm called Abraham.
Hi.
I've got a question regarding the first few days after childbirth. Maybe can you maybe give me a clarity of a woman after giving birth through C-section and a woman who was given birth through normal delivery? Do the number of days before you start the Kegel exercises remain the same?
Yeah, actually it does, because even though if you think about someone who's had a C-section, typically we would imagine that their pelvic floor might not be as damaged or as stretched out. But oftentimes what happens is that before they get to the C-section stage, or maybe it was scheduled C-section, but oftentimes it's like last-minute emergency C-section. At that point, the baby has already done the damage on the pelvic floor. The head is engaged, all the straining and the pushing has happened, and many times it's been going on for hours. So that pelvic floor is already stretched out, it's already damaged. In addition, during the course of the pregnancy, for those, all those months, the weight of the abdominal muscles are weighing more. There's more, the uterus has grown, the baby's weight. Everything is pushing down on the pelvic floor. So over time, even just through a normal pregnancy, that pelvic floor is getting stretched out. The bladder is pushing down on the pelvic floor. So immediately after birth, and actually many people will tell the pregnant ladies to do this as well, is the quicker that they can start reusing those pelvic floor muscles and engaging them, the quicker they're going to return to their normal size and function. So I wouldn't wait any more time for after a C-section, as long as that sometimes the doctors say that they don't want the incision area to be contracting too much after a C-section, but as long as the patient is able to do very minor Kegel exercises just in their pelvic floor, there's nothing wrong with them doing Kegel exercises after a C-section or after vaginal delivery, and starting immediately as soon as they're able to start.
All right. Appreciate.
Does that make sense?
All right. That is well explained.
Okay. So there's different ways that you're going to train the pelvic floor. You're going to teach the patient how to squeeze or hold on to their urine. That's one way to, cue them on pelvic floor exercises. And then has anyone heard of elevator exercises, where you imagine that the pelvic floor is a hammock or a sling at the bottom, and you ask the patient to pull the elevator or pull the hammock up to the next position in the elevator. So you're going up and then back down, and then you go up to level 2 and back down. Then you progressively get them to go higher and higher, and then slowly release the elevator back down. So we're doing sort of a, we're working concentric and eccentrically. You're going to ask them to lift up into the elevator, go up to level 5, and then slowly come 4, 3, 2, 1, back down to 0. So this is something that you can work with your patient in sitting or supine. You're going to have them visualize. So a lot of times I ask them to close their eyes. They're listening to your voice as you're guiding them through the exercises. Sometimes you can feel them if they're lying supine with their knees bent, and if you just give them a cue with a couple of fingers on their PSIS area, just underneath on their bottom, and you just do a very light pressure on that area as you're talking, that will help them. If they're having a lot of trouble finding those muscles, then that will help them find the muscles. You can just press up into that area, just on the side of their pelvic floor, not, just on the side. So, and then the last way that you can have them work on this is controlling the direction of urine to centralize the flow. So this means that the patient is actually urinating, in the bathroom, and you tell them when they're urinating, if their flow while they're urinating is going off to the side, if the urine is not falling directly center into the toilet, then you can have them work on pelvic floor muscles by controlling the flow of the urine, so that you're actually telling the patient, okay, when you're urinating, I want you to try and direct the flow of your urine to the center of the toilet. And this is going to help them work on their pelvic floor muscles. If there's an imbalance in those muscles, the patient will say that their urine goes off to the side. It doesn't fall centrally. And this is how we work on centralizing and getting more muscle balance. Or even just realizing that they have an imbalance by seeing, when they tell you that their urine is not flowing directly central.
Excuse me, Fozia.
Anybody have any questions about this?
Yes, I do. When you say that you control the direction of the urine, does that mean that maybe you contract the muscles, the pelvic floor on one side more than the other, or what? Unfortunately, here in Nairobi, today we are only men, so this is a bit puzzling for us.
Yeah, it is. That's exactly what it is. It's an imbalance. So like one side might be tighter, and when you're urinating, what happens is that, yeah, if one side is tighter or one side is contracting more than the other, then the flow of the urine will not go centrally. It will diverge to one side. And so when we see patients saying that this happens, when we ask women and they say that this happens to them, then we know that there's an imbalance, and we actually ask them to control it. When you're actually urinating, we tell them to concentrate on keeping the flow centralized. And just by them working on this and trying to centralize it, they're actually doing an exercise to control the imbalanced muscles. Does that make sense?
Okay. I also have got a contribution towards the same. Maybe when you are instructing the patient to, instructing the patient to control the urine maybe towards the center or the in direction that you would like. I also think it is better at that time to tell her to control the pressure, the amount that she's using in pushing out the urine, because the pressure also matters.
Yes.
I think that will also should be incorporated by the time you are doing the instructing about the direction over the where to urinate.
Yes, good point. That's right, good point. You can have them work on the amount of urine that's released. You can actually have them work on stopping urine, stopping and starting the urine flow. And that's also working on the pelvic floor muscles during urination, which is a very, very important time to work on it, because some patients have urinary incontinence, and their problem is they don't know how to stop the leakage. So when they are urinating and you're working on it, you can actually get them to work on these pelvic floor muscles during the time of urination.
Yes, Fozia, another question.
Any other comments or questions?
Yeah,
Yes?
there's another comment or a question. A lot of emphasis when it comes to pelvic floor dysfunction is put on exercises for women, and we don't have a lot of emphasis on male having the same problem, and actually men do have the similar problems. Do we have a different set of exercises, or we just give them the same set of exercises to do for men who have pelvic floor issues?
No, the same exercises. We would just maybe cue them differently. Sometimes, you can ask them to imagine lifting their prostate area instead of, like, that would be maybe the cue for them. But oftentimes I just use holding on to the urine. The urine is still the key that, they still need to stop and start their key urine flow using pelvic floor muscles. So it's the same exercises that they do, the same frequency, the same amount. You still want to work on a lot of pelvic floor muscles daily, when they have these issues. There's no difference for men.
Thank you.
Okay. Okay, so now we're going to talk about transverse abdominis, and frequently called the TA. Yes?
I once had a patient who didn't have urine incontinence, but she said her muscles was weak, that she was not, the partner was not enjoying the sex. So what
Yes.
we did, like we used to use stimulator, and we advised her to use ice.
Okay.
Was it effective, do you think?
Well, was there any like visual swelling or inflammation? Was there tenderness?
No, there was no tenderness. Just from her explanation, like she was. I mean, the husband used to complain. It's like
Okay.
the muscles after delivery didn't come back. So
Okay.
we are trying to do some exercise and ice and stimulation.
You know, if it was after delivery, then possibly the muscles were swollen or tender or, you know, damaged from the delivery. So ice is, you know, oftentimes there's tearing that occurs in the pelvic floor muscles when the you know, when the head engages, when the baby comes out, oftentimes there's a tear and in the pelvic floor muscles, and so there's a lot of swelling and soreness in the area. And you know, even in the hospital, they will give women ice packs to put in their vaginal areas to bring down the swelling from the tear and the pain. There's oftentimes pain in that area, so it's a good thing to do to use the ice. I don't know how effective the ice would be if it was like a long time after the delivery. You know, if there's no swelling or no soreness, then maybe you can even try some heat, just because these are like other muscles. If it's a chronic condition, then sometimes they're tight and more than they're inflamed. And so we might try heat instead of ice in more of the chronic conditions, and then they might get some relief from that. I've never personally tried that, but the ice is definitely, you know, in an acute setting, the ice is definitely going to help them with the pain and the inflammation. And then as far as the stimulator goes, you're talking about electrical stimulation?
Yes, it was.
Yeah, I mean, you know, again, it's a tool that you can use, but the primary thing here is to get these muscles to start working. So, you know, with sexual intercourse, if it's more of a tightness issue, then sometimes actually, I don't know if you guys have women's health physiotherapists there, but over here, sometimes they need to see a specialist who will work with them on trying to relax the muscles instead of we're kind of working on getting them to contract the muscles and to start engaging the muscles. Sometimes it's important that they work with the right therapist to actually learn how to relax the muscles. I had a patient who, you know, every time I had this patient who had some very serious issues with their pelvic floor, but also had issues with their spine. And every time I was working with them to contract the core and stabilize her core, her pelvic floor got very tight, and that was causing other issues. And she was seeing a women's health specialist in pelvic floor, and they were trying to get her to relax her pelvic floor, and I was trying to get her to engage her spinal muscles, and those two ideas were conflicting. So in the end, we had to stop the core stabilization because it was more important that she learn how to relax her pelvic floor. So sometimes it depends on the situation. Because these muscles are all connected, we can't just assume that we can separate them. When you're working on, you know, even if you were working on shoulder stabilization and the pelvic floor is kicking in and the patient has a tight pelvic floor, well, that might not work for that patient. So you got to keep in mind that your pelvic floor is part of your spinal core, and it works together. So the electrical stimulation, it's not. I mean, people use that, and it works, and it can work. But ultimately, you just want to make sure that they're doing the exercises, the correct exercises for what their needs are. Does that answer your question, Fatuma?
Yeah, you did.
Okay. Okay, so let's talk about transversus abdominis, location, and function. So the TA is called the TA, transversus abdominis, because it is the direction of the fibers. So these are transverse fibers. It's the innermost of the flat muscles of the abdomen. So it's on the inside of the abdomen. I'll just show you a quick diagram here. So if we look at a cross-section of the abdominals, you're going to have your rectus abdominis, right? Those are on the outside. Then we get into our oblique. So here's the external oblique. Then you have your internal oblique. And then you have your transversus abdominis. Yes?
Yeah. Sorry for interruption. Mercedes has a question. She's asking those who you what's bed? Is it called no, adults? Who you what do you call?
What is it?
Okay, she's asking if somebody adults who urinates in bed during the night, does it go to do something with the pelvic or core muscles weakness?
Yeah, yeah. I mean, it's going to be an issue of incontinence, of course, and incontinence has everything to do with pelvic floor involuntary contraction. So in the nighttime, your pelvic floor muscles, your core muscles, they're going to work involuntarily to, if your bladder is full, it's going to contract to keep the urine from leaking. And if these muscles are weak, then you're going to have leakage occurring. And it might also have to do with the nerve impulse to that area. So maybe these muscles are inhibited due to some sort of nerve dysfunction or neurogenic dysfunction due to something else. So what we would, when this is going on, what we want to do is we need to obviously work on it when they're awake and see if by training these muscles when they're awake, we can get some of the nerve conduction that happens to these muscles to come back. So a lot of times we call it training the pelvic floor. So we get them to do multiple contractions during the day so that your brain is connecting to those muscles and the nerve impulse is going. And so when you're sleeping, now these muscles are listening to the brain when the brain is saying you need to contract because we can't be letting this urine pass. So it's the same thing. The reason the incontinence happens when you're sleeping has to do with the involuntary muscle contraction that occurs. And yes, we do need to train the muscles when the person's awake in order to see the difference that happens when they're asleep. Is that okay?
Yes.
Okay. So back to the abdominals. So now we've got the transversus abdominis, which is on the inside. You can see it's like the deepest layer. If you look here, this is the outermost layer, and then we're going deeper and deeper. Here's the transversus abdominis. It's on the very bottom. So see the layers? So this is the outside, and we're going deeper, and this is on the inside here. And it's a flat muscle on the very deep edge. So this is what it looks like when they've taken all the other muscles out. So it's pretty high up, and it goes all the way down, and it's a flat muscle on the inside. It's connected to the bones. So it's very, very deep. And if we look at it from here, if this is the outside, the transversus abdominis is this layer on the inside, on the very inside. So it goes from the front all the way to the back, and it has some slips that attach into the back, into your back, into the multifidus as well. So it's all connected. So when you're contracting, you're going to pull in this whole inner layer. Everything's going to go in. Your abdominal contents are going to go in, and that's why we often tell the patients to imagine you're drawing your belly button in towards your spine, because we're trying to get this inside layer to contract. Okay, so it's the innermost of the flat muscles being placed immediately beneath the internal oblique. It helps to compress the ribs and viscera, providing thoracic and pelvic stability. It's vital to back and core health. It pulls in the protruding abdomen, hence it's nicknamed the corset muscle. So, a lot of times you'll get a lot of questions from women after childbirth, or, just generally, even some men who ask about how do I get rid of my protruding abdomen. And, you know, the pelvic floor, your transversus abdominis, in order to pull that whole area in, you're going to have to start engaging those muscles. But that's not going to completely take away your protruding abdomen. That's just one layer of it. Once these muscles are engaged, you're going to get a flatter stomach. But also, of course, you know, there's fat on the top, and there's other viscera, other fascia there. So it's not only the TA that's going to pull it, make it flat, but if your TA is not engaged, especially, you know, after it's been stretched out from something like if the patient is overweight or if they've had a pregnancy, then there's going to be a weakness in your abdomen, which is going to allow your muscles to, your skin to make it seem like it's stretched out. So initially, we do want them to start pulling in their lower abdominals in order to engage the transversus, which will help keep everything in. But training the rectus abdominis alone will not give one a flat belly. So this muscle contracts even when you're not thinking about it, when you're lifting something, when you're just moving your body's natural weight, stabilizing the spine and pelvis during lifting movement. So it just automatically contracts unless there's an injury or there's some sort of reason why the TA is not working anymore, in which case, for instance, after pregnancy, when it's been stretched out, sometimes this muscle has been stretched out so much that it's not working as well, and so we have to start training it. So this is an important thing. The contraction of the transversus abdominis reduces the pressure on the intervertebral disc in the lower back by up to 40%. So sometimes, you know, when you have a protruding abdomen, the weight and the pressure of that abdomen going forward puts extra pressure on the discs of your lower back. And if someone has a disc pathology or some degeneration, they're going to have low back pain, and sometimes what we need to do is reduce the pressure on that disc by having the patient work on their core muscles in order to reduce the pressure that's going on the disc. So having them work on transversus abdominis contractions will actually make their back feel better. Okay, so the most well-known method of strengthening the transversus abdominis is the vacuum exercise. So you have the patient lie in a relaxed position on their back and find pelvic neutral. Put your hands on the area of your abdomen that would be covered by the front of a bikini. So for the time being, we'll call this the bikini patch. Have your thumbs touching at the navel and your fingers touching at the midline, about 6 centimeters below the navel. So as you can see, we're not talking about where the navel is or where the belly button is. We're talking about an area that's lower than that, about 6 centimeters lower. Now imagine you have to zip up a very tight pair of jeans. Hollow the area under your thumbs and fingers towards your spine. There may only be a very small movement. Maintain pelvic and chest neutral. So you're not looking for a huge movement here. You don't want to see any movement in the back. You don't want to see any movement in their chest. You just want to see a small contraction happening in their bikini patch. Now imagine that the area under your fingers is being zipped together like a tight pair of jeans. Keep your body relaxed and maintain pelvic and chest neutral. So it's just a very small tightening that occurs very low under your belly button. Has anyone worked on transversus abdominis contractions with their patients before?
Not quite, but when people ask you for exercises to reduce the tummy, generally those are the exercises that we tell them to do.
Just you talk about pulling in their lower abdominals.
Yes.
Okay, good. Okay, so here's a picture of what you would be doing. You'd have your hands on your belly button and then your fingers on the bikini patch, and you're having the patient pull up and in. So like they're going to be trying to fit into a pair of tight jeans. Okay, so they're pulling up and in, and they're contracting the very low area of their abdominal wall.
Fawzia,
okay, yes.
would you be able to achieve the same effect when the patient is in that lying position, as is in that picture there, and then you tell the patient to just lift his head slightly off the floor?
Yeah, and you know, as long as they're not the thing is, when you start moving other body parts, like we talked about the global muscles and the stabilizing muscles, as soon as you ask a patient to lift something, they're going to engage their global muscle system. So this is, I mean, I would say yes to that answer, to that question, as long as they can, you're positive that their stabilizing muscles are working. The minute you ask them to lift something, you're going to kick in your global muscles, and we want to make sure that before their global muscles work, their local stabilizing muscles are already working. Okay, so initially, you're just going to have them work on stabilizing their local muscles, their core muscles, many times. When you're positive, you can feel that they're stabilizing using just their local muscles. Then we start progressing them and having them move things while they're holding on to their stable muscles. So for instance, like what you suggested, you have them contract first. You first have them contract their TA, and then you can ask them to lift their head up. If they lift their head up without concentrating first on contracting the TA, then they're just going to pull in other muscles, their global muscles, to do that movement. So it's very important that we first do everything without any movements. We don't want them to arch their back. We don't want them to press their back down. I don't tell any patients to do a pelvic tilt until I know that they can do a transversus abdominis contraction without doing any movement. Okay, so that's a big difference in the way that some people train the core. Sometimes people tell you to do a pelvic tilt. Well, the pelvic tilt, even when you do a pelvic tilt, their pelvic bone is moving. If the bone is moving, that means you're engaging a global muscle system. And we don't want to engage the global muscle system until the local system is engaged. So a lot of times people will do, you know, you hear about people doing Pilates or, you know, abdominal exercises, yet they say they do hundreds of abdominal exercises, yet they can't do a small movement like, you know, bend down to pick up something. So, you know, a lot of people blow through the core muscles, and they're using all these global muscles, and they're strengthening their global muscles, but that's actually hurting them. They need to focus on the core muscles first, forget about all those other harder exercises that they're doing, and just concentrate on getting the core activated first. Once your core has been activated multiple times, like we're talking hundreds of times, and you're positive that your core can be turned on without any sort of movement, then we can now go to progressing and having them do movements with limbs and with head and moving different body parts. So you can feel the difference in a patient who is contracting their TA and somebody who is using their rectus abdominis or they're using their hip flexor to contract. You want to be able to, you want to be positive that you're actually feeling a transversus abdominis contraction first, that they can produce that contraction, and it's easy for them. They've done it so many times that now they can do it without thinking about it. It just automatically kicks in. So just like, you know, when we did that exercise a little while ago where you were standing up and you were moving your arm, the reason your back muscles, your core muscles are working is because they're trained to come on when you move something. So if you had a back injury, or if your multifidus or your muscle in your back is inhibited, then you won't feel that contraction. And if you don't feel that contraction, then we need to train it. We need to get your brain to understand where that muscle is, how to contract it, and then once you've done it a whole, you know, many times, now your brain will automatically tighten those muscles when you use your arms, because now your brain knows, okay, these are the muscles that stabilize, these are the ones I have to turn on first. So does that make sense to everybody, that it's really important that you work on local stabilizing muscles before you move on to global muscles?
Yeah, makes sense.
Okay.
Yeah.
Mombasa, are you guys good? You can hear me?
Can hear you.
Okay, thanks. Okay, so now we'll talk about multifidus. So some of you might not be familiar with this word. Sometimes we don't talk about it a lot, but nowadays when we talk about the core, it's very important to know what the multifidus muscle is and where it is and how to train it. Okay, so consists of a number of fleshy and tendinous fasciculi which fill up the groove on either side of the spinous processes of the vertebrae, from the sacrum all the way up into the cervical spine at the axis. So if we look at it here, it starts all the way from the bottom. Oops, sorry. All the way to the top. You're going to have your multifidus in your spine. Okay. I don't know why I'm not. Oh, there we go. Okay. So the multifidus is a very thin muscle. It's deep in the spine. It spans 1 to 3 joint segments, and it works to stabilize the joints at each segmental level. The stiffness and stability makes each vertebrae work more effectively and reduces the degeneration of the joint structures. So you can see here you have the multifidus starting at the spinous process, and it goes down, and it goes and it fills up the space in the groove here. So when we're feeling for the multifidus, we're going to go on the spinous process, and we're going to go in between the spinous process and the transverse, and in the space that's in the groove here. That's where the multifidus is going to be. And so in some cases, depending on the angle, it's going to span 1 joint here, or it can span up to 3 joints. It can cross a joint and it can span up to 3 joints. So when the multifidus contracts, what it does is it gets shorter and it stiffens the spine. So it controls how your spine is moving and working and stabilized. Okay? So that's why we need to train it. So here's another picture. So the multifidus is quite deep, and then you have all your other longissimus and iliocostalis spinalis. Those are on top. Those are your erector spinae. Erector spinal are the global muscles. Even in the cervical spine, you're going to have your multifidus is going to be very deep, and then you're going to have your splenius and your semispinalis capitis and all the other suboccipitals, and then your muscles that go over top. They're going to be more superficial. Those are the ones you're going to feel when you're just touching the skin. But the multifidus are the ones that are on the spine. They're very deep. Okay? So again, when we're trying to train them, we're not looking for movement, because when you move, you're going to get your global muscles working. We're going to work these muscles without movement at first, because we want to train the local muscles before we train the global muscles. Here's another picture with some of the muscles are removed. Your multifidus, even up here, you know, they're going from the spinous process in between, and they're coming down. And so we're going to find them on the outside of the spinous process in the groove. And that's where we're going to feel for it. Okay, so all along the spine. In the thoracic spine is a little bit harder to feel, but you know, we'll do some exercises to work on them. We know that they're working. And then the lumbar spine, again, they're a little bit more fleshy again, or muscular, so you can feel it a little bit easier in this area. Okay? Just another example of how the multifidus is down here, and then you've got some of your other overlying muscles on top. Okay, so when does a multifidus dysfunction? So as soon as, within minutes to hours following a discogenic lesion, the multifidus at that level becomes inhibited. So the multifidus, pain, we talked about it earlier, pain can also inhibit a muscle, and oftentimes in the spine, the multifidus is inhibited when there's pain or when there's a lesion. Furthermore, the multifidus does not automatically return to its pre-inhibited state, but we can train the multifidus. The research seems to support that those plagued with lower back pain have a loss of dynamic spinal stability through multifidus inhibition. We thus lose control over the spinal segment's neutral zone. So what is the neutral zone? So there's a model called the Panjabi model of the neutral zone. The neutral zone is the range of intervertebral motion produced with minimal internal resistance. So it's the range of movement that that the spine will go through with minimal resistance. So the neutral zone is an area that you want your spine to be moving in, but if that neutral zone gets larger, then we tend to have instability or hypermobility. So if your multifidus are inhibited, if your segmental stabilizers are inhibited and cannot maintain this neutral zone, then you get instability or hypermobility, and that can result in pain and dysfunction. So poor control of the neutral zone. So this sets up an environment that leads to increased stress in the involved vertebrae, and ultimately the possibility of a stress fracture or stress reaction and neurogenic dysfunction. So I don't know, Macau, you were asking me about the neutral zone. Does that explain a little bit what the neutral zone is?
Yeah, that explains it.
Okay. So the multifidi are not the whole stabilization system, but it's the best indicator we have on how the system is responding. The whole system, the multifidi, the pelvic floor.
Excuse me, Fozia?
Yes.
Fozia?
Yes.
I'm Vidya from Dar es Salaam. I'm
Hi.
sorry, I didn't understand the neutral zone yet.
Okay, so the neutral zone is, basically you have to think of it like if one segment, you take one spinal segment, L4-5, how much can that segment move? How much can it go into flexion and how much can it go into extension? That amount of movement that it has without any resistance, like I'm not talking about how the muscles can move it, but how let's say you could put your hands on that spine and you can physically move it from flexion to extension, okay, that one segment. The amount that joint can move from flexion into extension is called that joint's neutral zone, without any resistance. So if a joint gets very lax or hypermobile, then that neutral zone is going to be bigger. You're going to be able to move that joint in a greater range. And if that neutral zone gets too big, if that joint gets very loose, then the patient can get pain because it's hypermobile or it's moving way too much. And then, the thing that controls the neutral zone are these muscles, these multifidus, and the core muscles are the ones that control how much that spine is going to move without resistance. So if your multifidus stops working, then your neutral zone, the joint starts moving way too much, and then you can get pain from the hypermobility.
Question for Zia.
Okay, thank you.
Okay, yes?
For Zia, back to the neutral zone. When you're assessing the neutral zone, would you be doing an active movement or a passive accessory movement?
You would be doing a passive accessory movement.
Okay, thank you.
Because the neutral zone is not you're not using muscles to see what the neutral zone is all about. You're trying to see how much movement there is without internal resistance, so without any muscle resistance. But having said that, it's not something that you can do passive accessory glides, but this is it's almost an abstract concept. It's not something that you can pick up and move this bone, because we can only do passive accessory glides on the joints, right? We can't. So we can tell from joint glides if we think a joint is stiff or if we think it's hypermobile. From that we can say, okay, they probably have a bigger neutral zone. But it's not something we typically write down. We don't typically assess for it. We're just assessing the joint glides. We might be assessing their overall global movement, and we can think in our minds, okay, this neutral zone has increased. What could be the reason for it? Maybe their multifidus is inhibited. But it's not typically something we go and assess. Okay? So multifidus. Now how do we recruit the multifidus? So the big thing is that you want to isolate the multifidus activation, and it's a little bit harder to do. But once you practice this a lot of times on patients and on yourself, you're going to be able to feel when the multifidus is contracting, and you're going to be able to do it without global muscles contracting. So I would have the patient, the easiest position again is having them lie down on their back. And you can I typically go in and put my hands on their lower back about 2 finger widths away from the spine. So I put both my hands under their back. I'm leaning over them. I'm putting my hands underneath their back. And I ask the patient to contract or flex or tighten the muscles into your fingers. So the big thing here is for you as a therapist is that you're not pushing into the muscles. Don't be pressing really hard. And this is something that as you practice, you'll learn how to relax your fingers and still feel the muscle contraction. So you're going to put your hands underneath their back in the area close to their spine, and you're going to ask the patient to contract into your fingers. And most of the time, they won't know what to do. Most patients do not know how to just contract those muscles, and you have to give them a little more feedback. So you might put some pressure there and say, okay, can you feel my fingers? I want you to contract into my fingers. Or you can tap the area and see if that will help them. They still might not be able to contract the multifidus. And if they can't contract the multifidus, then we're going to use the other core muscles to help them. So if they still can't contract the multifidus, I'm going to say to them, okay, imagine that you are trying to stop your urine. So I'm going to have them tighten their pelvic floor muscles, and I'll say, okay, tighten your pelvic floor muscles and go underneath your buttocks and go up, take that contraction right up into your lower back. So we're not just stopping with, we're not happy if they just do a Kegel. That's not a multifidus contraction. We want them to be able to, if they're going to use their pelvic floor, they have to connect it to their multifidus. So I'm going to say, I'm going to put my fingers under them. I'm going to put it on the multifidus. I'm going to lightly press. Don't press too hard. You're going to just press, and you're going to say, okay, contract the muscles here. I want you to imagine you're stopping your urine. You're going to pull up on the pelvic floor and go underneath your buttocks and connect to your lower back. So you have the patient try this a few times. Sometimes they still don't get it, but oftentimes you just need to give them some practice. They just need to keep practicing, and your fingers are going to be there, and you're going to say, okay, relax. And the other thing is that you don't want them to contract and hold it. You're asking them to contract, okay, relax. Again, tighten into my fingers and relax. Tighten into my fingers and relax. So each time they need to relax those muscles so that they can contract them again. Remember, these are very tiny muscles. They're not big muscles, and they're not producing any movement, right? So they're just little tiny muscles in here. So you're not going to see any movement. You don't want to see the pelvis moving. You don't want to see them moving their legs. You don't want to see them moving their head. They're only contracting the muscles in their back. And we're trying to feel, and what you're going to feel is a very slight, you're not even going to feel a huge contraction. You're just going to feel a little bit of pressure building up in your fingers. And when you actually feel someone contract their multifidus in your fingers, you'll know, because you'll feel it tighten and get hard. And then when they relax, you'll feel the muscles get soft again. And then you ask them to tighten, and it'll get hard and soft. And you just keep having them practice with you. Sometimes patients will say that they can only feel it when your hand is there. Then they don't know how to do it after that. That's just a matter of practice. They just have to practice. You can do it with them for 5 minutes in your clinic. Just have them practice, and then, of course they have to go home and practice at home as well.
Fozia.
So, yes.
This is something that I've been trying to do, this multifidus recruitment, and
Okay.
I've been doing it my own way. Maybe I've been wrong.
Okay.
Normally what I do is that I tell the patient to lie prone, and
Okay.
then I tell them to try as if they are going to lift their legs. I put my hand on their lower back, okay?
Okay.
And then I tell them to try and act as if they want to lift their legs without actually getting the movement. And as soon as I feel them starting to contract, I tell them stop, okay? So that you don't actually get a movement. I find it easier that way. I don't know whether that is effective or not effective. So that in time they learn to know how much actually contracts the multifidus and how much now recruits the rectus spinae.
Yeah. Yeah, that's an interesting way to do it. You can definitely, as long as there's no actual lifting of the leg. My only concern would be that if they're thinking about lifting of their leg, their brain is probably already engaging the erector spinae. So what you should try, and I get patients to do this in prone as well, just take out the whole lifting of the leg and just have them try and contract. You can have them start with the lifting of the leg idea, but then have them then back off on that and just say, okay, have them lie prone, put your fingers in the muscles again, and just have them imagine that they're tightening the muscles in your fingers. Because as soon as you ask them to think about doing a movement, they're going to, at some level, they're going to still recruit their erector spinae. And you don't want that at all. So it's a very deep, deep, deep muscle, and it's very easy. Remember we talked about the threshold. It's very easy to engage something that has low threshold. So, you want to make sure that they're engaging the right fibers and not getting the easy ones to come on. People are used to lying, like everybody who lies on their stomach once and then they lift their head, they're going to very easily recruit their erector spinae. It's very difficult to do multifidus without any other movement. So you can do, I start out people in supine and put my fingers because supine's a little bit easier position, but then I have them do it in prone as well. In prone, when it's easier for you to feel it in prone because when they actually contract it, you're going to feel like a actual bulging into your fingers. And if you feel erector spinae, the erector spinae is going to be longer, right? So you're going to feel it a little bit, you're going to feel more of a band going up into their thoracic spine. We don't want that. We want a very local contraction because multifidus contraction should be just where your fingers are. If you move your fingers up one level, then you can ask them to do the next level and the next level and the next level. When you have them do an erector spinae contraction, that whole spine is going to contract, the whole erector spinae contracts together. And so it's not easy to separate it. But the multifidus, you can actually put your fingers on L4-5 multifidus and have them contract just there. And then you can go up to L3-4 and say, okay, now I want you to try contracting just here. So in prone, it's a really easy way to, move up with the multifidus and get a very specific contraction. So one more thing, so we start in, I often start them in supine, and if they can't do it, sometimes some people can do it in prone, or you can start in prone and then go to supine, but those are very low level multifidus contractions that I want them to start with. And then if somebody still cannot, if you still can't feel the multifidus just by them, using the cues that you've given them, you might need to do an augmentation. So there's a couple ways you can do it. You can have them lie on their back and then lift just their ankle, just their feet. They're not lifting the foot. The heel is still on the bed. They're just doing dorsiflexion of the ankle, and their heel is still down. And then you can have them very gently first try to tighten the multifidus, and then they can very gently dig their heel down into the bed, and you'll immediately feel a contraction in your lower back when you dig your heel. And that's just to have the patient understand what that multifidus feels like. If they really, really can't get it without moving, then you can try a heel dig on the same side to see if you can feel the multifidus kicking in. Some people are so inhibited that there's no way the brain can connect to this muscle, and they can't do a voluntary contraction. So then we do the heel digs until the brain gets a little bit more sensation to that area, and then the voluntary contraction comes easier. So that's one way. The other thing I do sometimes is I put my fingers on their PSIS on the side that I'm feeling, and I'll just gently, again, just like I did with the pelvic floor, I'll press up into the PSIS area and then have them contract into their multifidus and see if I can feel it. And sometimes people just need a little bit of guidance or a little bit of feedback. So we call this, we're training out the multifidus. So repetition is key here. So I tell my patients to do 200 contractions a day. They're not doing them all together. They're just spacing them out. Maybe they do 50 when they wake up, and then 50 after lunch. Before they go to bed, they do a whole bunch. So just spread them out, and they don't have to do them lying down. Once they know how to contract the multifidus, they can do it anywhere. It's a little bit easier in sitting than standing, but you can have them practice it when they're in the car, or when they're watching TV at every commercial. Any chance you can give them, you should encourage them to practice their multifidus contractions. There's no harm in doing postural or local stabilizing exercises as many times, because these are the muscles that we want to have working all the time. They're the endurance muscles, so we don't have to be afraid of giving them too many. Okay, so any questions so far about multifidus? I think it's a good idea to practice amongst yourselves as well. Practice on your colleagues and see if you can feel it and contract it. People who have learned about it will be able to contract it a little bit easier. So if you practice on each other, you can feel, you'll be able to feel how to do it and how the other person is doing it, so that you know how to teach your patients. All right, so.
Only one question before we proceed.
Yes?
Yeah, one question before we proceed.
Mm-hmm.
Yeah, now that we know all about the multifidus and everything, and let's say in a patient with the low back, it's something that it's a common way of management over here, intermittent lumbar traction. So
yes.
How do you think, how advisable is it now that we've seen how important where the multifidus comes in? So how important do you think, how would you advise, how much would you advise for the intermittent lumbar traction?
We used to have the lumbar traction in our clinic. We don't have it anymore. We do have a similar thing, but honestly, I don't use it as much anymore because I find that the core stability training is much more valuable. It's the time that they spend. Some patients, they get a lot of relief from traction. Especially if an acute disc or somebody who has a lot of muscle spasm or something, they just really feel like the intermittent traction gives them some relief. But, Peter, the big thing is that you don't replace it with the stability training. You can do it if your patient really, or you might do it for the first couple of treatments, and then, and then you say, okay, let's try without it, and let's work more, let's spend our time more valuably with learning to do this. This is more important. This is something that you can really the time that you spend with your patient has to be time that's going to give them more value. And they'll come back to see you if they're getting some value, right? So the problem with the intermittent traction is it's very temporary. You're going to get some relief, but it's not going to last. As soon as they stand up, the effects of gravity push that disc right back together. So the multifidus, on the other hand, if you can get them contracting their multifidus, what the multifidus does is it contracts and it actually it stiffens the spine, but it also pulls it a little bit apart. So if you think of the multifidus at each level, it's going to kind of pull the disc, pull that joint, give it a little bit of traction anyways. And the multifidus working all the time is going to give more effective traction to your spine than doing intermittent traction for 15 or 20 minutes. You're just not going to, your multifidus working 24 hours a day is going to give you way more stability than just doing the treatment for a short period of time.
Fozia, I have a contribution to that.
So in the long run, it's more valuable. Yes?
One thing I want to contribute on this, Peter, because in Kenya it's common practice to give patients a corset, a lumbar corset when they have a disc problem. I think these are quite an issue that I've had to discuss with a lot because I find that the corset does have a role to play, but the role of the corset is limited because basically what the corset attempts to do is to cause the stability that is done by the core muscles. So my argument with the doctors here is that it is good to give the corset, yes, but only for a very short duration of time because, as Fozia has just said, when you get an injury to your disc, initially you get inhibition of the fast motor units, and those are the core stabilizers. So during that time, that acute phase where you have inhibition of those slow motor units, then you might need to use a corset for a few days, and then you start activating them. Okay? Now, once they're activated, then you should stop using the corset because in the long run, what the corset does is to weaken your muscles. So I don't know what contribution Fozia has got to that.
Yes, that is exactly right. That's exactly what I would say to that. You don't want, the other thing is that when a patient comes to see me on day one, I'm doing that person a disservice if I don't teach them how to do the multifidus on day one, because that disc needs the blood supply coming to that area to help it to heal. And if I'm not teaching that multifidus contraction on day one, they're not going to get the maximum amount of blood flow to that area, and that's what the disc needs for healing. So you need to, no matter what happens, no matter, how much pain that patient is in, you can give them the corset that day one, but you better be teaching them how to do multifidus day one as well, because that patient needs to get control over the multifidus in that area. And the longer you wait, the more inhibition there will be in the multifidus, and the more damage there'll be to the spine because there's no stabilization for that spine. And what does the disc do? The disc is there between the levels. Let's see if we can find a picture here. So your disc is between the two vertebrae, and the disc, the function of the disc is to create stability. Now, if you have a spinal compression or a disc lesion, that stability is gone from that one level. And what happens is the pain shuts the multifidus down. So you have a double whammy now. You have the disc problem because they don't have the stability from the disc, and they're not getting stability from the multifidus. So while the disc is healing, the best thing we can do is get them to start contracting their multifidus so at least they have some stability. And giving them a corset, like Mina said, is giving them some stability in the short run. But the bigger long-term solution is making sure that their multifidus is contracting so that they have good spinal stability for the long run. So you can give them the corset, but make sure that the patient doesn't get reliant on the corset, and make sure that they're, intermittently taking it off and contracting their multifidus in the meantime, so that they're getting some stabilization from their own local system rather than using some external system. And the other thing I would say is, I think it is a common practice in East Africa to give the corset more than it is in North America. We hardly ever, give a corset to a patient. The only time I really see some, some sort of stabilization unit given is sometimes if there's a pelvic, so let's say there's an upslip or their SI joint is hypermobile, and we're trying to really hold something in place, physically hold it in place, and we don't feel that the muscle system can do it. Then we're going to give them like an SI belt or something just to create some sort of compression so that they can get a hold of their muscle system. But even for discs, oftentimes I will use taping rather than a corset, because the taping is quite localized to, again, when you put tape on someone's back, it's just like your fingers are there. You're starting to give them some sort of feedback so that their muscles are feeling the tape, and then it's kind of reminding the patient to turn those muscles on. So sometimes taping their back is much more effective than using a corset, because the corset creates a stiffness in their hips and all the way up until their rib cage. Whereas really all we need, the only area we need to stiffen or to create some stability is in the actual segment that the disc is the problem. So many times I will just put tape on their back instead of giving them an external device. Have you guys tried taping for backs?
No.
Okay.
We have a few of the physios here do practice taping. Not all of us.
Okay.
It's a skill that is still new and people are still learning.
Okay, and on MedBridge there are probably a couple of courses on MedBridge that show some taping techniques, and taping is really just something that you have to practice. It's not, it's not a very hard skill. It's not something that you have to specialize in. It's just something, pretty much all taping works. Even if you're a little bit off, if you don't have it perfect, it's still going to work to some degree. So it's just a matter of practice, and the more patients you try it on, the more you'll see how it works, and you'll be more confident using it. Okay, so we'll just finish up here with functional core stabilization. So core muscle activation during functional activity. So you want to preset the core prior to the activity. So just like just like we talked about, you want to preset it. So you want the patient to be able to think about tightening their core. Like oftentimes you can have patients try this, have them do an activity such as climbing up the stairs. So let's say they have low back pain and you want them to climb up the stairs and they say, oh, it's just too painful. Okay, now have them try it with a tightened core. So have them engage their TA, multifidus, pelvic floor all together and say, okay, tighten up, and now let's try the stairs again. And there should be an improvement in their function when their core is active, pre-activated. So we can progress functional activity as core stability improves. So, we can have them add resistance. As soon as you add resistance or change something like their surface, or you close their eyes, immediately you're going to need more core recruitment in order to stabilize. So you're going to need to, so by adding resistance, if you add a little bit of TheraBand, if I was to do that same movement that we did earlier, shoulder flexion to 90 degrees, but now I had some TheraBand resistance, you would feel a lot more core recruitment and even erector spinae recruitment, because now your body has to counteract that resistance. So we moved from single joint to multiple joint training. So like I said, we were working on just activation in neutral first, and then we would add in limbs, and we would add in different positions. We go from supine to prone, then quadruped, and then kneeling. So the order that I would progress somebody is non-weight bearing first, so no resistance with the core pre-activated. Then we can go to quadruped, so 4 points, no resistance with core activated. Then we're going to go to kneeling, and when you're in kneeling, you can start adding some resistance, and then standing. Then we do standing exercises. So this is the order that you would progress somebody if you're working on trying to get them stronger. So you started non-weight bearing, have them do some exercises in non-weight bearing, then we go to quadruped, do 4 points, then we go to kneeling. In kneeling, they're just taking the weight of their upper body up to their knees, and then once they're standing, now they have their full body weight. So anyone have a question on this method, the stabilization progression? Does that make sense? Yeah? Okay. So in summary, the importance of addressing core for any injury, we're going to training from low to high threshold. We're going to start with the local muscle activation, then go to global muscle strengthening. We're going to connect the core to all functional activities to achieve maximum results, and then we're going to progress the functional activities using the 4x4 method, which was the chart I just showed you. So do you guys feel like this is something you could start practicing right away, start working on with your patients? And really, you can work on this with any patient. It doesn't have to be a patient with low back pain. I didn't really talk about cervical, but with the cervical muscles, you want to make sure that you're activating the cervical muscles as well. And for the cervical muscles, same thing, I have them lie down, put my hands on the side of the spine, and again, we're just asking them to tighten the muscles in the back of their neck. And some patients will be able to do it, some won't. Sometimes I ask them to press their tongue to the roof of their mouth. If you press your tongue to the roof of your mouth and imagine that you're tightening in the back of your neck, usually you can get that, you can feel the multifidus in their neck.
Fozia?
Yes.
This is Vidya from Dar es Salaam again. I have just one question.
Sure.
In the acute care setting, how soon do you think can we start training these patients with core stabilization exercises?
Everybody can start on day one. There's no need, even in the acute setting. I mean, as long as a patient is, like if you're going to teach them one exercise, and I'm assuming you're talking about acute, like low back pain?
Yeah, acute low back pain, especially what we talk about the interverse, meaning PIVD setup, where the patients are much in pain, and I wonder if they would quite be, be able to localize such minimal movements where they have to quite concentrate so much.
Yeah, and it's your call on that. I understand completely that if they're in a lot of pain, they can't even concentrate. You might want to start with some modalities just to calm them down, and sometimes I do it at the end of my session. If I've done some modalities, maybe some heat or ice, or some electrical stimulation, maybe a little bit of gentle massage. If you do some soft tissue
and
work.
we also have the spasms there. So when we ask the patient to contract further into the spasms, it's only going to increase the pains, I guess.
Right. But remember, the spasms are occurring because they're global muscles. Those are the global muscles that are spasming. So once you have those under control, so that's why sometimes I use tape, because the tape, when you put tape on somebody's back, what you do is you give them a little bit of stability. It's as if, if somebody sprained their ankle and they were going to go play a sport, you would tape their ankle to give them some stability so that they could play, right, or walk. It's the same thing for your lower back. If your back is in so much spasm, that you can't even move because every time you move that the muscle spasms are occurring. You have to help them stabilize somehow. And you know, the corset is okay, but it's only for people who are moving around. A corset doesn't help you when you're lying down. The corset doesn't help you unless you're actually standing up and moving, right? Maybe a little bit in supine, but mostly it works when you're standing because there's pressure. So the tape that I do, that's usually very good at bringing down the spasms. So even if you just put it across in the back, like in the center of the back with some tape, what it does is it provides some local stability for them to calm down the spasming. And then once their spasm has gone down, now you can say, okay, even though we don't want, the thing is you have to make sure they're not contracting the erector spinae. You want to make sure they're just contracting the multifidus. And if you don't think they can do the multifidus without getting the global system, then you just have them start with Kegels and have them just do the pelvic floor, or just have them do the TA. Because if they're lying there, they can do the TA and the pelvic floor without contracting their erector spinae. So once you tell them to do that, let's just teach them, okay, day one, we're not going to do multifidus, we're just going to do pelvic floor. So you can teach them how to contract the pelvic floor, tape their back, maybe put some E-stim or some heat or ice on their back. Now the next day you go in, if it's a little bit better and they can concentrate, now see, okay, pelvic floor, let's see if we can get a little bit of multifidus contraction. Maybe it'll work acutely, but you know, it really depends on the patient, but I don't think you should think that they can't do it. Just try. Try. Every day you should try. Maybe day one they'll get too much spasm. Maybe day two it'll work a little bit. Maybe day three the spasm will be gone and they'll be able to do it. But you still need to try every day to get that multifidus working, because when the multifidus starts working, the spasm will go away. The spasm is there because there's no stability on the spine.
Yeah.
Does that make sense, Vidya?
Yeah, very much. Thanks. And also I feel from the way you presented, it will be easiest for us to start with the pelvic floor exercises, isn't it? Because that's easiest of the three, pelvic floor and then the TA.
Yeah.
The multifidus seems to be the most difficult of the three.
And
so we keep the sequence up of pelvic floor, then the TA, and then the multifidus.
Yeah, but the big thing is that you don't forget the multifidus. It's very, very important. I don't often teach the TA anymore because the TA automatically works when you do the multifidus. They're all connected together, and I don't want the patient to only think about the front muscles. They need to think about the front, the middle, and the back. If you teach them the TA and they get used to doing the TA, they might forget about doing the multifidus. So just be careful with that. Don't think that you're doing it's enough to do the TA and the pelvic floor. The multifidus is the most important until they learn how to contract and isolate the multifidus. They're not going to get spinal stability just with the TA and the pelvic floor. The multifidus is really the key muscle for back patients. Okay, the TA typically is very easy for them to learn because most people have learned at some point. Maybe they've learned to do a pelvic tilt, and you just have to have them forget the pelvic tilt and just do the TA. But the multifidus, most patients have never heard of it before. So you really, really need to focus on that. And I would say, you guys just need to keep practicing on each other and just keep practicing, because the better you can do it, the better you can teach your patients. If your body you can show your patients, I have my patients feel my multifidus all the time. And if they can feel it on somebody else, sometimes they can figure out what they need to do. So really make sure you concentrate on that multifidus with your back patient.
Okay, thank you.
Okay, any other questions, anybody? Mombasa, Nairobi, any questions?
No, okay.
Okay.
Thank you very much.
Okay, so you know, we didn't go over. I wanted to have you guys just quickly talk to me about MedBridge. I'm going to just show you the MedBridge screen really quickly here. So Nishi had sent an email about or a text message about how long do you guys think that you could watch a MedBridge tutorial? How are you planning to do that? Are you going to do it together? Or are you going to do it separately? How would you prefer to do that?
For Zia, we are having a bit of challenge in Nairobi, a bit of challenge with MedBridge.
Okay.
So far, I've not managed to get it open properly. Yesterday, I went to the IT department, and I've got somebody there who is working on it to find out what is stopping it from opening properly. So, as it is right now, we are not able to access MedBridge very well.
But so, when you access? Oops, sorry. Let me stop this.
I was going to say, can people
when you were able. Hello?
Go ahead, Fauzi.
Oh, sorry. My question is, when we talked about it before we gave you the proper login, were you able to do the trials?
Yes, actually at that time I talked to them, and they increased the bandwidth and we were able to open. But after some time it refused again. So the gentleman at IT told me that he's not sure whether he's thinking maybe some kind of filter which is stopping it from flowing through. So he's working on it right now to find out what the problem is.
Okay. Okay, so right now that's not working. Nishi, did you have a question?
Well, I was wondering if people can access it on their own personal devices.
On my phone, I'm able to access sometimes at night when I think when the network is not busy. At night, I'm able to access on my phone.
So I don't know if, Fauzia, do we know if two people can be on at the same time?
I think they can. Like I've tried it like with my phone and my computer, and I seem to be able to do it with both.
That may be another option.
So what would you guys like to do? Would you like me to assign a MedBridge course that everyone watches and then we discuss it? Or would you like to give me some topics that you've found on MedBridge that you're interested in?
Yeah, I think if you can sign in and then we watch, that would be fine. But if we manage to get the IT guys to sort us out, then I'll let you know.
Okay. So yeah. This one that I've opened up right now, can you guys see that one on MedBridge? It's called the hidden link.
Yes, we can see it.
Okay, so this one has, this one is a little more of an advanced course. It talks about some of the things that we talked about today. It talks a little more about spondylolisthesis and this neurogenic dysfunction. This is a very, it's a very interesting topic, because it goes a little bit further than what we talked about today. It talks about how the core, what happens to the core, or what happens to the segment when the core is inhibited, what happens neurogenically. So sometimes, and then it talks about how to assess different assessment techniques and examination of the core with the stabilizers on and with the stabilizers off. But this is one area that, if you're interested in this core stuff, then this is a good one to watch. But we were thinking that maybe you guys wanted to learn a little bit. I think there's been some questions about vestibular rehab and doing vestibular stuff. Is that something that you want to maybe tackle next?
Yes, I think we can do that next.
Okay, so I'm going to, there's quite a few vestibular, if you go into courses here in MedBridge, you guys will see over here on the side that there's different topics. So if I was to look for vestibular here.
Actually, there are quite a few on MedBridge. I've tried to open. One time I was able to watch one, then I couldn't watch another after that.
You couldn't, oh, after that. Okay, so if you go into this one, balance and vestibular, it'll load all the courses that talk about vestibular. So see there's vestibular rehab office examination, vestibular identification. These are all done by the same person, so they're probably very similar or they're sequential. Vestibular rehab case studies, that's again the same person, so there's probably like once you've watched one you can watch the case studies. So there's quite a few different ones. We could just start with you know, I don't know, are you guys familiar with examination of vestibular, or are you looking more for treatment ideas?
I think vestibular rehabilitation is something that is completely new to us. We have not been practicing it, so I think we'd like to go to it from the beginning to the end.
So then I think this one is probably vestibular rehab office examination. It talks about the anatomy and physiology, pathophysiology, bedside office exam technique. So it's going to be, you know, probably not too long. It says approved for 4 hours, so it's probably going to be less than 4 hours. I would say probably, here, let's see. I'd imagine it's going to be a lot less. Maybe about 2 hours to do it. So how much time do you think you need before, you know, we go over this? How much time, like, do you think a month is enough or you need longer?
I think for the, as soon as if we're able to open, as soon as we're able to access, I don't think it should take us that long. Because I think a month should really be enough. A month should be enough.
Okay. So what about Mombasa and Dar? Are you guys, I know, Fatuma, you just got it. Do you think if we assign you a topic, that's what you want to do?
Yeah, actually Fatma is not around right now. She's just moved out for a while.
Okay.
But I think that will be good to work on the topic for about a month, and then we can have a discussion over it like this.
Okay. All right. And Peter, have you started using MedBridge yet?
I tried sometime mid last week, and I had some difficulties, just like Mr. Menez is saying. But my IT friends are trying to sort it.
The internet, okay.
Yeah, the watchman. I know the second thing about the assignment of topics. Let's say. I think it's I would also go for that. It's more.
The vestibular?
Yeah.
Okay. All right. Okay, so I will, I think this is a good one, vestibular rehab office examination. I can send you the name of it in the email if that's easier. And then you guys can just confirm when you're able to start watching it, and then we can talk about discussion.
Yeah.
That's okay. Thank you.
Okay. All right. Yeah. Okay, thank you. It was wonderful talking to you guys today, and let me know if you have any questions.
Well, thank you so much, Fauzia. Thank you. All
right. Bye.
And then look. Bye-bye.
Bye.
Bye.